This is a quick lecture just to go over some of the laws that apply to fraud and abuse. May seem obvious, but the government has to spell it out. So again, you might think, I know what fraud is, definitely. But if you look at just some of these examples of the things that are occurring worldwide, so these are all from 2014, and you can see the amount of the fines, the enormous fines that come, 350 million here, 70 million here. These 11 people are charged. They're going to go to jail. In this case in Florida, 7.5 million for fraud here, 15 million of fraud here. And then, of course, there's taking bribes. It does seem like it's obviously a lot wrong, but it is done. And so definitions for what's wrong and what you're supposed to avoid doing have to be laid out. And they are in several laws. So as defined by CMS, fraud is knowingly submitting or causing to be submitted false claims in order to receive payment, or knowingly soliciting, receiving, offering, and or paying some remuneration in exchange for or to elicit services which would then eventually be reimbursed. This can affect us in the laboratory, or making referrals that are prohibited by law for specific health services. Then we also have other kinds of fraud where you have healthcare professionals who are being held accountable for these. So the healthcare professional, the person with the license, in other words, which by the way is you, can be held accountable for these instances of fraud. So it's not, the clerk, the billing clerk necessarily who gets dinged. It's the person with the license who generated the false claim. And then because CMS sets the law of the land, all insurance companies will also follow their rules. So insurance company if you do fraud against an insurance, a particular private insurance company, Aetna or something like that, then you're talking about civil litigation. But Aetna will report you to CMS, and CMS will tear your books apart, and that could lead not only to more civil litigation, but also criminal charges. Some of the examples of fraud that come about, particularly in the lab, things that can come to fruition in the lab. It's just really a short list, but we have to be very careful about the way our systems work so that we can avoid them. One of the big ones is billing for services ordered but never performed. So the classic example of this is the urinalysis that was ordered by the doctor in the morning was never collected. It used to be that the bill was generated upon the order. That's no longer done. The bill is usually generated for almost every lab result. It's generated on the result. Okay, but there are some that might need to be a charge for the collection, things like that. So it makes ordering more complex, and it's also one of the reasons we need to be sure to clear our pending logs, make sure that we get everything completed. Then billing for tests that are at a higher level of complexity than the services actually provided or documented. So if your doctor orders an India ink on a CSF, which is it's not complex, it's manual, a relatively cheap test, and this CSF gets to the lab and the supervisor says, no, I know that that's a high-risk patient. Let's instead do the latex agglutination test, which is more complex, marginally, but it's more complex. And the key thing is it's more expensive. So you're not allowed to change the test order without written authorization, meaning the doctor has to reorder the more complex test. Billing for services not actually performed or supplies not provided, or both, by the billing lab, and this includes falsifying records to include delivery performance of such things. So classic example of this, if you get a culture in the micro lab and you get, you get an organism that you don't normally do a sensitivity on. Let's say you get a Neisseria meningitis, and normally most labs only do a beta-lactamase on that. Doctor says, no, I want a sensitivity on that. Well, you can't just start doing sensitivities on Neisseria, so you would have to send that out. So you send it out. When the results come back, you can't plug it in to the sensitivity area of any culture, which would then generate a bill for a sensitivity that you didn't actually do. So, the doctor's going to receive a bill from the send-out lab, from whatever reference lab you got, or the patient, I should say. So you can't just fill in areas that exist in our computer system and forget that, hey, this generates a cost to the patient, but we didn't actually do that sensitivity. So while you can use that spot in the computer, you always have to remember to go in, and there's usually a way for the laboratory to access billing so that they can delete those charges, because that would be inappropriate and it would be fraud. And then paying for referrals of patients who are beneficiaries of any federal health care program. So basically what they're saying here is the lab can't go to, the local FBI office and say, if you send all of your officers for their, yearly physicals to us, we'll do all their lab work and we'll give you some benefit. We'll, anything from a cash incentive to the HR department there, even down to we'll send you, test kits so that you can do spot drug testing. Can't do anything like that. Okay, that would be considered a kickback. Examples of abuse that exist for obviously billing for unnecessary medical services. If you can't just run, hey, let's run a pregnancy test on every woman that comes in the hospital. Could be safer for them if we know that they're pregnant right away. Yeah, but that's unnecessary. If there is no predetermined reason, you can't have a policy like that. Down to the little things, you're looking at a patient and you're like, I know them. I know that patient. Let's get a whole bunch of tests so they can feel better and take it back to the doctor. Can't do that. Overcharging for services, obviously, you have to pay what it costs. You have to charge what it costs. And misusing codes, and we've talked about this before, upcoding or unbundling codes. Using a code for a service that reimburses at a higher rate than the service actually performed. An example of this is, in some cases, cardiac markers. Let's say cardiac markers, if you order that test, let's say it costs $50. I'm just making that up. Let's say it costs $50, but the cardiac markers run stat in the morning. Maybe we charge $55 for those because of the way we process them. It costs the lab more, and so we charge a little bit more. You can't use that code for, say, a routine cardiac marker that appears in the ER at 5 o'clock in the afternoon. Yeah, it has to be the appropriate code. Unbundling codes, billing separately for services. So you don't order a Chem 7 one test at a time. You bundle them together as a Chem 7 because that's the cheaper version. If the doctor only orders a glucose, that's fine. You don't do the Chem 7, you just do the glucose. If the doctor only orders electrolytes, that's fine. You just do the electrolytes. But if the doctor orders glucose, electrolytes, and kidney function, then you can't run them separately. You must bundle them, and that is no matter how he ordered them. If you know they should be bundled, you have to bundle them. So every hospital, every lab is required to have a compliance program that allows both the inspectors as well as the employees and the supervisors to catch instances of fraud. And they don't count a mistake, an honest mistake, as an accident. That's still fraud. So where we normally, most normal people think of fraud as an intentional act, with CMS, it does not have to be intentional. It could be a problem with your systems. It's still fraud. So, the fine is the same. You don't get a cheaper fine because it was an accident. So everything is fraud. when it comes to CMS, and that's important to remember because there's no such thing as an honest mistake. Okay, and the mistakes that we're talking about, mistakes obviously incorrect coding. Usually that's something written into your systems, into your computer systems. That would be a problem. But at the doctor level, because we don't code things in the laboratory, if the doctor codes something incorrectly or orders something that you know to be an incorrect code, I think I've told you before, I've had a doctor or two order an FDA antibody without ordering any RPR. The FDA antibody, as you know, is the confirmatory test. We don't do the confirmatory test without doing the screening test. That would be considered fraud. So you have to do the less complex test first. And all it takes is a phone call to the physician saying, the insurance won't pay for that. You have to do the screening test first. That's what most people do. And usually the physician will say, oh, I just made a mistake, and do that the right way. Okay, you can change it then. It becomes a phone order. Then the other things that the compliance programs are supposed to address are inefficiencies, and that would be with ordering excessive tests. So your systems have to have built into them limits and flags that will warn physicians when they've exceeded the limits for excessive testing. So, for example, most hospitals have limits on the number of, say, CBCs that you can run per day, or urine cultures, or in micro it's pretty easy because it's one per day. So, you just flag it and say, no, I already did this patient this day. For like CBCs, though, you would have to have a compelling reason why you would need to do a second CBC in the same day. And it could be there. The patient might be actively bleeding. The patient might have received a transfusion, but those all have to be documented before you can do the second CBC. And that's the point. And those all have to be written into your systems so that if the doctor goes to try and order the second CBC, that a flag will come up. Okay, why are you ordering this? You already have one. And the doctor can enter the mitigating circumstances. What's the reason I'm doing this? Then we have, of course, there have to be ways within their compliance programs to catch those instances where bending of the rules, where upcoding or unbundling have occurred. How are we going to find them? Okay. Sometimes it's subtle. Doctor orders electrolytes in the morning, orders kidney function later, orders a glucose finally. I mean, he's all over the place. He ordered a Chem 7. He just did it different hours of the day. You have to find a way to catch that. And then, of course, intentional deceptions. There has to be a way to monitor and to audit your own systems, some kind of mechanism of internal audits where you can find any services that were billed but aren't provided, hadn't been provided. And usually those can be pretty easily found, if you write your ordering systems well. Okay, but this should be a cyclical program so that you have, you're going to have audits by JCO and by CMS. But you should have internal audits. You should have mechanisms where you go through your systems. You do some kind of test, follow a specimen through, make sure that everything went through right. So some of the statutes that apply, you have to know, okay? So for example, there's the Federal False Claims Act. And in this one, you've got fines up to and including imprisonment if you submit any kind of false claim to the federal government. In this one, you actually knowingly have to, so there has to be intent with the Federal False Claims Act, okay? The fines can be up to 3 times the amount of the damages, plus up to $21,563 per false claim. Interesting number, don't understand it. But now, each claim is separate, so while we bundle the test, right, we have to bundle the test into a Chem 7. If that Chem 7 is illegal, that's not one claim. That's a claim for each of the 7 parameters. Okay, so the government doesn't unbundle or doesn't bundle or anything when we're talking about fines. So you see what's going to happen when that occurs. Okay, remember with lawyers, these are all become negotiating points. The anti-kickback statute. This makes it a crime if you or an entity within your organization knowingly and willfully offers, pays, solicits, or receives any kind of remuneration, directly or indirectly, that'll induce some kind of referral, which would then eventually be reimbursed by CMS. Okay, so this is, a lot of this is some hairy kind of areas, because this is kind of how the healthcare system works, right? Pharmacists, pharmacy salesmen go to doctors' offices, and they bring with them a lunch for the whole staff, and sits with the doctor and gives them, maybe they do an in-service or some pills or whatever. That's kind of how it's always worked. The salesmen want to get your attention, so they provide things. For our service, for our purposes, the technology people of the Murio, BBL, all of them, they used to bring stuff to try and sell. We have this new plate, we want you to see it. Oh, by the way, here's some candy. Or we have this, machine, we would like you to buy it, and we'll buy you Christmas dinner. Whatever it is. That's it. You can't. It cannot appear to to be that way. You can't have any evidence, any appearance of there being some kind of pay for play with this. Okay, and this can include imprisonment as well. Usually this refers to, if you have some kind of pain management place, and they say, we'll refer all of our patients to your imaging institution, and so you'll get all of our referrals, and we'll make sure we order an MRI on everybody, and then all of that would be a kickback. If you then refer your sick pay, it's all considered kickback. So there are safe harbors that exist in there, regulatory safe harbors, because there has to be some kind of collegial atmosphere between the services provided and the people who are referring them. So that has existed, and one of the problems is an imaging place can hardly get off the ground unless a physician is associated with it. So what if you own an orthopedic place and you decide to open an imaging service? You have to have some kind of mechanism where doctors can still do business in this atmosphere. The physician self-referral law, also known as the Stark Law. A lot of these are going to sound redundant because they kind of are. This one prohibits physicians from making referral to any services that will be payable by CMS where the physician, that same physician, has some kind of ownership or investment interest. And then they added the caveat, because initially there was no caveat, unless an exception applies. And again, that's the orthopedic who decides to open an imaging center connected with, but still, the businesses are still separate. So you're not allowed to make the referral there. Now, technically they are allowed to make the referral there, but they cannot restrict the patient from there. The patient can go wherever they want. And that's what has to be made clear to the patient. They don't have to go to that physician's place. Okay? But no imaging place would open up unless they had some interaction with an orthopedic or something like that, where they were going to get business. And you can see the penalties there. And the key thing is you can eliminate that physician from CMS programs, potentially. A criminal healthcare fraud statute. Again, this has to have intent, prohibits knowingly and willfully executing or attempting to execute a scheme in concoction with the delivery of or payment of healthcare benefits with the intention of defrauding any healthcare benefit program or obtaining any money or property owned by or under the control of healthcare benefit program. So this is like sort of a RICO for the healthcare industry. This is really where you're talking about a serious organization. So you hear about these in the news from time to time. These pain management or orthopedic clinics where it's kind of like, we'll give you a script that says whatever you want so that you can get, workers' comp, and we'll take all of your stuff and we'll bill it to CMS, frequently never having done any of the tests. So these are pretty elaborate schemes. So this is kind of the larger overall, talking about the organization, a RICO kind of statute again for the healthcare department. Okay. Now the statutes there all require intent, so you have to knowingly do that. But it's not just if intent will bring you the criminal crimes, but remember, it doesn't require intent to have the civil penalties or to be excluded from CMS. Okay, administrative Medicare fraud and abuse penalties. These are the penalties that exist that are available to them, and they're administrative, so they don't necessarily require a big trial for this to go through. So these are just extra things that they can add, where, for example, the exclusion statute allows you to kick you out of CMS, which is probably the biggest issue, because if you're kicked out of CMS, a lot of other insurance carriers are going to drop you. And then Medicare population, that's everybody over 65. That's an enormous amount of the population. So if you're a physician and you can't see any of them, that's especially of the sick population. Okay, so the things that include, those are things that you've been convicted of: Medicare fraud, patient abuse or neglect, any other felony convictions that are related to healthcare fraud, or even theft or fiscal misconduct, felony convictions of unlawful manufacture, distribution, prescription, or dispensing of controlled substances. So, you get caught with drugs, you can be excluded from CMS. You are convicted of tax fraud, you can be excluded from CMS. These are administrative things that they can just say, hey, you're out. They can also exclude on some other misdemeanor situations. Anything related to healthcare fraud, obviously, and in controlled substances. They want to keep those doctors away from CMS patients. Then if there was some kind of suspension or surrender of your license, meaning your medical license or your professional license, they could definitely eliminate you for that. Providing, basically falsifying your services, providing unnecessary or substandard services, engaging in unlawful kickback arrangements, or defrauding the health education loans or scholarship obligations. They added that one. So if you have a loan out there for your med school and you said, I won't pay it back, they can exclude you from CMS, and that means until it's a way of the federal agencies to work together. This does not have to go to a court. The OIG, the Office of the Inspector General, the OIG has the ability to do this. And then finally, the civil monetary penalties that exist are pretty outrageous. You have, just thousands and thousands of dollars. And remember, these are updated annually. The penalty, so this is not the cost. You're always going to have to reimburse the cost, but then there's a penalty on top of that. And these could really, hospitals run on such thin margins, these could really bankrupt an institution. And remember, that's per violation. So imagine each lab test ordered, each one on its own is a violation. So that's a lot of potential errors. Okay, and then of course it's not just the cost, but it's up to 3 times the cost that you defrauded. So if you defrauded the government of $100, just their reimbursement can be up to $300, and then the penalty on top of that. Okay, and now $100. That's not what the lab fees that we ask for reimbursement are thousands of dollars for inpatients. Okay, so these are just some of the, I know this is redundant, but you do have to know these. They are asked on the boards. Okay, they will throw in a couple of questions about this. But that was a short lecture.